Hello, my name is Kelly Morris, and I will be presenting information on why I believe the emergency department should redesign the workflow process for patients checking into the emergency department and information regarding my recommendation on implementing a rapid assessment unit to help alleviate overcrowding in the ER. Emergency care in the United States is ever-changing and metamorphoses in response to both internal and external factors, and imbalanced resources are triggered by several factors, including lack of timely and efficient access to primary care, increasing patient acuity, decreasing number of emergency and urgent care facilities, increasing illnesses during influenza season, and the frequent flyer phenomenon. Emergency departments across the United States have been experiencing an ever-increasing influx of patients seeking non-emergent treatments since the implementation of the Affordable Care Act. As a result, EDs across the country have been overstretched, leading to overcrowding. Overcrowding in the emergency departments is concerning as it delays patient evaluation by emergency providers and increases patient morbidity and mortality, lengthy ED wait times and length of stays, increased patients leaving without being seen, lost revenue for the emergency department and the facility, and decreased patient satisfaction scores. Crowding, according to the American College of Emergency Physicians, is defined as the identified need for emergency services exceeds available resources for patient care in the emergency department, hospital, or both. Increasing patient satisfaction decreases return visits to the emergency department and decreases the incidences of patients filing complaints and lawsuits. A patient's perception and expectation of receiving care in the emergency department are the main contributing factors to a patient's satisfaction. Variables that can be changed easily to positively alter a patient's perception of their care are attitudes and professionalism of staff, competent and efficient medical care, approachability and friendliness of the provider, and cleanliness of the facility. More difficult for the facility to change are the patient's perceptions and experiences of the amount of time they wait to see a provider. The lengthiest wait times are for those patients arriving through triage who have lower emergency severity index scores and do not require extensive evaluations and treatments. To increase patient satisfaction and safety and emergency department throughput, as well as emergency department revenue, and decrease door-to-provider times, as well as length of stay and left without being seen ratio, a recommendation will be made to implement an entry process workflow redesign in the form of a rapid assessment unit. Currently, at Confederated Health Hospitals and Clinics, a Level 2 trauma center, the average daily patients seen through the emergency department is 350, with 75% of the patients arriving through triage. The average door-to-provider time for Emergency Severity Index, or ESI, Level 3 patients is 3 hours, with our average emergency department length of stay being just under 6 hours. ESI Level 1 and 2 patients are immediately roomed in the acute care section of the emergency department, and ESI 4 and 5 patients are seen through fast track, with an average door-to-provider time of 45 minutes. The average left without being seen percentage is 6.7%, though the emergency department's goal is 2.8%. This slide contains the Emergency Severity Index, or ESI algorithm, used by emergency departments in the United States to rapidly assess the severity of patients' complaints and medical issues in order to assign an ESI score. This score alerts emergency staff to the order in which patients should be seen in the emergency room. Level 1 patients are in need of immediate life-saving emergency care. Level 2 patients are high risk and need emergent care. Level 3 patients are not in immediate danger, but will need emergency treatment as soon as it can be provided to prevent conditions from worsening. And ESI Level 4 and 5 patients have no life-threatening conditions and need only basic medical care. Under the current triage process entry workflow, patients arriving by ambulance are screened by a registered nurse, or RN, as they enter the emergency department. patients with an ESI score of 3, who are not bedridden and do not have emergent medical needs, and all ESI 4 and 5 patients are sent to triage to begin the triage process. ESI levels 1 and 2 and ESI level 3 patients who cannot sit in a chair or wheelchair and have emergent medical needs are immediately roomed in the acute area of the emergency department. All patients arriving to triage are triaged the same, regardless of whether they arrive by ambulance or private vehicle. After the patient has been entered into the triage system by the admitting personnel and has received an identification badge, the patient then walks over to the triage window and speaks with the greeter RN, who records a preliminary chief complaint and assigns a preliminary ESI score. The patient is then sent to the triage booth to be assessed by a screener RN. The screener RN documents a chief complaint and performs a focused assessment, provides immediate emergent treatment if warranted, and assigns a final ESI score. The patient is then sent to another booth where the emergency department technician obtains vital signs and performs an EKG if necessary. ESI 4 and 5 patients are sent to the fast-track waiting area, while the ESI 3 patients wait in the main triage lobby until they are seen in the acute area of the emergency department. The lobby RN is responsible for rounding on the ESI 3 patients waiting in the lobby every hour, while the emergency department technician is responsible for updating vital signs every 2 hours. The triage nurse is responsible for ordering protocols. This includes labs, breathing treatments, x-rays, etc., on all ESI 3 patients and communicates with the provider at triage for appropriateness of ordering CAT scans, ultrasound, MRI scans, additional labs, and vascular scans if warranted. The goal of ordering protocols on ESI level 3 patients while waiting to see a provider is to decrease the length of time the patient takes up in a bed in the acute care area of the emergency department once they are roomed. The theory is that if a patient spends less time in an acute care bed, patients waiting in the lobby will be seen sooner by a provider. In reality, ESI level 3 patients have only a minimally decreased length of stay because of initiation of protocols and triage, as providers are mandated to see ESI levels 1 and 2 patients before ESI 3 patients. ESI 3 patients are spending up to 60 minutes waiting in an acute care room for initial contact with the ED provider, which further decreases patient satisfaction, as their expectation is that they will see a provider immediately once they are brought back to an acute care room. When the patient is brought back to an acute care room, the patient first encounters their primary RN, who asks the patient why they are being seen and what their chief complaint is, does a focused assessment, and goes over medications and allergies as well as medical history. The patient then awaits the arrival of the ED provider and is asked again why they are being seen and what their medications, allergies, and medical history are. The current triage entry process workflow requires the patient to go through 6 steps before they are seen by a provider and requires that the patient tell their chief complaint and reason for emergency room visit a minimum of 4 times during their emergency department stay, which causes a further decrease in patient satisfaction. To decrease emergency department overcrowding, door-to-provider times, length of stay, and left without being seen, and to increase overall satisfaction of ESI level 3 patients, this writer recommends that the triage entry workflow process be redesigned and streamlined to reduce the number of steps the ESI 3 patient must take prior to seeing a provider, and to reduce the number of times they must relate their chief complaint and reason for ED visit. Efforts to ease overcrowding in the emergency department and positively impact patients' care experience will require allocation of additional resources. These resources include additional treatment rooms, increased personnel resources, changes to patient workflow in the electronic health record system currently in use, which is EPIC, and major workflow process interventions. The recommendation for the implementation of a rapid assessment unit is aimed at decreasing the door-to-provider time, length of stay, and left without being seen ratios of ESI level 3 patients meeting specific rapid assessment unit requirements. Appropriate patients to be seen in the rapid assessment unit, or RAU, are ESI 3 patients not needing extensive treatments or workups, ESI 4 and 5 patients to be seen after all ESI 3 patients have been evaluated by a provider. ESI 3 patient exclusion criteria. This will be ESI 1 and 2 patients, any patient requiring isolation or sedation, any patient that is agitated or intoxicated, or any patient requiring cardiac monitoring is unable to sit in a chair, and those who are normally unable to ambulate. The RAU should contain a minimum of 8 treatment rooms, each containing an exam table, Philips monitors to take vital sign measurements, a wall-mounted computer that is equipped with the Epic and Medicopia programs, basic supplies for patient care, and a sink. A supply room should also be in the RAU, equipped with the Omnicell medication cabinet, all other supplies deemed necessary for patient treatments in RAU, as well as a prominently located code cart, ice water machine, and pneumatic tube system, and printers for discharge paperwork and prescriptions. The RAU will need a centrally located nurse provider workstation, a co-ed restroom, phlebotomy area for lab draws, a results pending area containing a nurse workstation with 3 computers, 18 recliner chairs for patients to sit in while waiting on diagnostic results and conclusion of intravenous therapies, and 2 conference rooms where providers can update patients on their treatment plan and diagnostic results and provide a disposition. This slide is a diagram I have created showing the patient flow from the ED lobby through the RAU process. Each step is color-coded with arrows showing patient flow. This chart also shows the different rooms and supply areas that are needed in the RAU. This diagram will be explained on following slides. Patient flow in the RAU in this recommendation and section of this paper is modeled after the Pod 4 process at Salem Hospital. Figure 1 shows a diagram of the proposed RAU infrastructure and patient flow and is located on the previous slide. Patients will enter the ED lobby and will be simultaneously seen by the admitting personnel who will enter the patient into the Epic system and apply an armband, and an RN greeter who will enter the patient's chief complaint into Epic and assign an ESI level. ESI 1 and 2 patients will be immediately roomed in the acute section of the ED. ESI level 3 patients will be given a card with a room number on it and directed to the RAU where they will self-room. This is denoted in Figure 1 by the yellow arrows. ESI level 4 and 5 patients will be directed to the lobby to wait for a room in Fast Track unless all ESI level 3 patients have been seen, in which case patients will be split between Fast Track and RAU. Patients going to RAU will be limited to 1 visitor per patient to preserve room for RAU patients. Once roomed, an ED provider and an RN will meet the patient in the assigned room. The provider will assess the patient while the RN takes vital signs. The provider will then enter treatment orders into Epic from the computer in the room, and the RN will carry out orders when received. The patient will then be transferred to the phlebotomy station if needing blood drawn for labs, then to the results pending or RP area, or straight to RP if not needing labs. This is denoted in Figure 1 by the gray arrows. And the RN will give an SBAR report to the RP-RN. If needing diagnostic imaging, an imaging technician will come to RP to get the patient for the scan, and the patient will be returned to RP once the scan has been completed. The patient will wait in RP until all diagnostic results are back and all treatments are completed, such as intravenous fluids or antibiotics, pain medication, or oral medications. The patient will then be moved to a conference room, which is denoted in Figure 1 by the black arrows, where the provider will meet the patient, give diagnostic results, and provide a disposition, either further diagnostic treatments, patient returns to RP, denoted by the gray arrows in Figure 1, or discharge, denoted by the green arrows in Figure 1. To track patients during the RAU process, the RAU trackboard must be built in Epic. Once built, the patient's progress through the RAU process can be tracked. After self-rooming, the patient's banner will turn yellow, indicating that the patient is ready to be seen by a provider and an RN. Once the patient has been seen by the provider, the patient's banner will be turned to gray to reflect that the patient's disposition is pending. meaning that they are waiting for diagnostic results and/or completion of ordered treatments. The patient will be moved to RP after initial treatments are completed in the treatment room. While waiting in RP, the patient's banner will remain gray. If the patient is waiting for blood to be drawn for labs, the Epic trackboard will have a symbol of a syringe in the lab column next to the patient's name, which will disappear once the blood has been collected and sent to lab. If the patient needs any type of medication, a purple ball will be placed in a column next to the patient's name. Once the medication has been acknowledged in Epic by an RN, the purple ball will disappear off of the trackboard. If the patient needs diagnostic imaging, the Epic trackboard will reflect such, and the name of the imaging test will show up in red in the imaging column next to the patient's name. Once the imaging studies have been done, the imaging name will turn black on the trackboard. When the imaging study has been read by a radiologist, a green checkmark will appear in place of the imaging name on the trackboard. Once all of the diagnostic results are back and all treatments have been completed, the patient's banner in the Epic trackboard will turn dark blue and the patient will be escorted to a conference room for disposition. If the patient requires further treatments or diagnostics, the patient's banner will be turned back to gray in Epic. If the patient is being discharged, the banner will turn green and the patient will be discharged by the provider or RPRN as warranted. For efficient and timely care of the patients being seen in RAU, this writer proposes that 2 providers are stationed in RAU, staffed by either a nurse practitioner, physician's assistant, physician, or a combination of any of the 3. Proposed RN staffing for the treatment area of RAU is 1 nurse to 2 patients, or a total of 4 nurses. 1 emergency department technician should be assigned to the treatment area of RAU to assist the RN with the appropriate tasks and patient treatments. The results pinning area should be staffed by 1 RN per 6 RP patients, or a total of 3 RNs. 1 emergency department technician should be assigned to RP to assist the RP nurse with patient needs such as using the restroom, providing beverages if the treatment plan allows, assisting patients out to the lobby or into vehicles when discharged, escorting patients to the conference room for physician consult for disposition, and other tasks as delegated by the RP nurse. The phlebotomy station should be staffed with 1 phlebotomist when there is a low census of patients in RAU, and 2 phlebotomists during peak census for blood draws to expedite lab results. As the recommended workflow process redesign suggested by this writer will require significant allocation of financial, personnel, and physical space resources, this writer proposes that initial implementation be done as a test of change using the outpatient area of imaging. As the ED currently uses the outpatient imaging staging rooms to treat patients during after imaging hours during peak patient census, the test of change will not require building additional space for an RAU as infrastructure is already in place. The existing outpatient staging area of imaging has 6 rooms, which contain a bed, TV, and mobile Philips monitors for taking vital signs. Additionally, the staging area has a desk that has enough room for 3 chairs and already contains 2 computers loaded with Epic and Medicopia programs. A mobile computer could be used for additional computer access. The area also contains a pneumatic tube system, code cart, printer, beverage station, and a co-ed restroom. There is no Omnicell located in the imaging staging area that contains ED medications, meaning the test of change RNs will need to go to the ED for patient medications. A mobile cart should be put together containing the most commonly used patient care supplies, including bandaging material, phlebotomy and intravenous catheter supplies, and other necessary items. Additionally, a mobile linen cart will be needed in the staging area for sheets, blankets, pillowcases, washcloths, towels, and gowns. The staging area should be staffed with 1 provider, 2 RNs, and 1 emergency department technician to run a successful test of change of a mini RAU. Hours of operation should be 1800 to 0200 during the ED's peak patient census and imaging's after hours to eliminate competition for space. The test of change should be run for 21 days, 7 days a week, in order to have enough data collected to analyze. Emergency departments in the United States are plagued with overcrowding, and as a result, patient satisfaction has been steadily decreasing as their perception of wait times and access to care are not congruent with their expectations of timely and efficient emergency care. While the sickest patients are seen by a provider immediately, and fast-track patients are being seen quickly, the ESI Level 3 patients are waiting longer as emergency rooms are getting increasingly busy. To increase patient satisfaction, decrease length of stay and left without being seen ratios, as well as patient mortality and morbidity, many emergency departments are implementing RAUs to decrease wait times of ESI Level 3 patients and reduce ED overcrowding with great success. This writer has recommended a workflow process redesign in the way that ESI 3 patients are seen in the emergency department, and further recommends that if the test of change in implementing an RAU on a smaller scale is successful, a permanent implementation of a full-scale RAU should be investigated as a viable solution to decreasing patient dissatisfaction, length of stay, left without being seen ratios, and ED overcrowding.